serosa or iatrogenic if the tumor ruptures during surgery. Peritoneal metastases occur synchronously in about 8% and metachronously in about 15%. Cytoreductive surgery, this term have started with the work of Sugar Baker. Sugar Baker is the godfather of peritoneal operations and godfather of HIPEC. He is a surgeon from the United States, and he did a lot to these hopeless patients that were considered inoperable and nothing had been done to them for several years. He invented the peritoneal cancer index, which entails division of the abdomen into parts, and parts of them are heavily infiltrated, like the upper jejunum, lower jejunum, because they are the fixed parts of the intestine, and we can reach the number of peritoneal cancer index by collecting the number of areas affected and also by the tumor size. The evolution of peritoneectomy procedures have been palliative before 1980, but with the coming from 1980 to 1995 started the HIPEC and the EPIC, which means early perioperative intraperitoneal chemotherapy. Then it passed into cytoreductive surgery, that means complete resection of the tumor and remaining only few millimeters of the tumor with peritoneectomy operations. From 2000 to 2010, registration started in different parts in Europe and the United States with randomized trials and development of expert centers. Later on, curative treatment was achieved with progress in the HIPEC and the drugs and the intensive care units. And after that, preventive therapy is now the issue. The residual disease, we should leave as less than 1 millimeter to achieve complete cure. This is called CC0, or complete cytoreductive zero. Hyperthermia, which is added to the technique, have many values. It enhances the effect of chemotherapy, and it allows penetration of the drug inside the peritoneal cavity and the organs, and it has few side effects. The most commonly used drugs are mitomycin in the United States and oxaliplatin used in Europe. Other drugs like fluorouracil, idriamycin, fulfixiri, and others are used in this technique. This is the machine used. It heats the drug with the solution inside, then tubes are inserted into the peritoneal cavity and the tubes come out, and the circulation is maintained for 90 minutes to 2 hours. There are two techniques. This is the closed technique. We close the abdomen on the tubes, and the other open technique, we circulate the drug while the abdomen is opened. The first randomized trial for this technique was published by Vic Verwel, Dutch surgeon, who did follow up 8 years for cytoreductive surgery and HIPEC versus systemic chemotherapy in patients with peritoneal carcinomatosis, and it was published in the Annals of Surgery. He divided the patients into two groups. Group 1, cytoreductive surgery plus HIPEC, which entails mitomycin for 90 minutes, and the other cytoreductive surgery plus adjuvant systemic therapy. And later he gives the systemic therapy for both. And he then calculated and studied the cases. For systemic chemotherapy, he introduced 5-fluorouracil, and for the HIPEC arm, mitomycin, which is given several times during the operation. And this was the disease-specific survival by treatment. There is improvement in overall survival by 10 months. Median overall survival was 22 months for patients who received the HIPEC versus 12 months who received chemotherapy, regular chemotherapy. And this was also linked to the type of resection. R1 at that time means residual less than centimeter, R2 more than 2 centimeter, and R2B gross residual. The criticism for this study is that it entailed 17% of cases of appendicular cancer, which have a different pathology, and also he used fluorouracil, which is a weak drug. He didn't use the recent drugs, which might have better results. Also, he had high incidence of mortality because he worked on advanced cases with high peritoneal index. Another randomized trial was done by the French group, François Quenet and Dominique Elias and else in France, to study the cytoreductive surgery plus hyperthermic chemotherapy versus cytoreductive surgery alone. This is called the Prodigy 7. It's a multi-center randomized study. And the pattern of the study entails colorectal peritoneal metastases with synchronous metastasis, age between 18 and 70, complete cytoreduction, and 6 months of systemic chemotherapy with peritoneal cancer index less than 25. And here, the first arm used HIPIC, the second arm used only systemic chemotherapy. And the primary outcome was the overall survival. The study started with 396 patients, then some patients were excluded before, and some patients were excluded during surgery, and it ended with 2 arms. First arm with 133 patients whom were exposed to cytoreductive surgery and HIPIC, and the other to cytoreductive surgery alone with systemic chemotherapy, and they were matched in the performance status, in the localization, and in the incidence of synchronous metastases. He found that the overall survival was 41 months, significantly longer than expected, and it was better with cases which had complete cytoreduction. The HIPIC arm here was bidirectional, means that he used chemotherapy before the introduction of HIPIC. This was immediately before the operation. And the author concluded that similar survival outcomes and increased morbidity and mortality were associated with the HIPIC arm. So the Prodigy 7 did not support the use of HIPIC with high-dose oxaliplatin over 30 minutes. And this is the criticism for this study. They used 5-fluorouracil, which is a weak drug, and the duration of perfusate was 30 minutes only, and it should be at least 1 hour. And the choice of oxaliplatin. Oxaliplatin is known to be a weak drug, and the mitomycin is much better, and overestimation of the effect of HIPIC on overall survival. Another study was used for adjuvant hyperthermic chemotherapy in patients with locally advanced cancer, which is called the COLOPEC trial, and it consisted also of 2 arms after resection of the primary colorectal cancer, which are advanced cases or perforated. They divided into 2 arms. One arm adjuvant HIPIC, including oxaliplatin, and the other adjuvant systemic chemotherapy only. And then they were followed both by systemic chemotherapy for 6 months, and they did diagnostic laparoscopy after 18 months to see the effect of the treatment. And the primary outcome here was peritoneal metastasis-free survival at 18 months. Adjuvant HIPIC consisted here of intravenous fluorouracil and leucovorin before the start of surgery, and this is called bidirectional therapy, and 19% developed peritoneal metastases. Conclusion: in patients with T4 or perforated colon cancer, treatment with adjuvant HIPIC with oxaliplatin did not improve peritoneal metastasis-free survival at 18 months. Routine use of adjuvant HIPIC was not advised as well. Another study done by the French group also, second look surgery plus hyperthermic chemotherapy versus surveillance in patients at high risk of developing colorectal metastasis. This is called Prodigy 15. And here, the resection was done for colorectal cancer with either perforation or metastasis in the ovary. These are high-risk patients. And then they received afterwards adjuvant systemic chemotherapy, and they were randomized into 2 arms. First arm, second look laparotomy, and the other group only surveillance. And the primary outcome was disease-free survival at 3 years. And this is the design of the study: 150 patients divided into 2 groups. Group 1, surveillance group, and the other group which received the systemic second look surgery plus HIPIC, and the results were comparable as regards the risk factors, which entails 1 risk or 2 risk factors, primary site and involvement of lymph nodes. Second look surgery consisted of performing exploratory laparotomy with cytoreductive surgery if there is dissemination of disease, and HIPIC with intraperitoneal oxaliplatin for 30 minutes. They also received intravenous fluorouracil. And the primary outcome after 3 years, disease-free survival, there was no difference also between both arms. And no difference in the 5-year survival, as we see, between the 2 arms, 68 versus 70%. 70% astonishingly was with the surveillance, better than the re-exploration. Another trial for evaluation of HIPIC is called CAIRO-6, which is perioperative systemic therapy and cytoreductive surgery with HIPIC versus upfront cytoreductive surgery with HIPIC for isolated resectable colorectal peritoneal metastases. And here, perioperative chemotherapy appeared safe, and there were similar proportions of macroscopically complete cytoreductive surgery, suggesting lack of benefit of perioperative therapy. This is a new trial going on in the Spain called GCOP MMC for mitomycin, phase 4 randomized clinical trial to evaluate the efficacy of HIPIC with mitomycin after complete surgical cytoreduction. And the patients here included with peritoneal cancer index less than 20 and for 90 minutes with mitomycin, and they undergo complete cytoreduction, and the primary outcome is the 3-year peritoneal recurrence-free survival. Another meeting was done between the PSUGI. PSUGI is the Peritoneal Surface Oncology Group International, headed by Sugar Baker, and the RINEP, which is a group, French group for rare peritoneal tumors. And they agreed upon consensus with 140 experts that HIPIC protocol with highest possible agreement, the preferred HIPIC regimen for these patients is based on high-dose mitomycin. This is a new going on system for the peritoneal carcinomatosis in colorectal cancer established by the American group. They confirmed that these operations should be done by expert surgeons in visceral resection. They can do urological and GIT and biliary operations, and they can deal with any complication in the pelvis. And the current regimen, intraperitoneal chemotherapy, mitomycin, and they also added new drugs, which are the anti-epidermal growth factors, cetuximab, and the bevacizumab, the antivascular endothelial growth factors. And we here see the complicated or diagram for these cases. These cases will be screened by physical examination and all types of radiation, and they will count the peritoneal cancer index, and they have 2 views for the metachronous, then the synchronous. For the metachronous, they depend on the, after numerating the peritoneal cancer index, they divide the patient into either low-risk group or high-risk group. And this is confirmed by the lymph node metastasis, by the age of the patient, by the grade of the tumor. So if metachronous peritoneal metastasis is limited, it goes into low risk or high risk. But if there is widespread disease, it goes to the site of systemic chemotherapy from the start. Low risk patients, we will consider laparoscopy to be sure that it's a limited disease. If it is a limited disease, it will be complete cytoreduction surgery followed by HIPEC, then chemotherapy. If there is high risk disease or high peritoneal cancer index, the patient receives the first chemotherapy, then restaging by laparoscopy, and if progression, it goes to the way of chemotherapy. But if it improved and the peritoneal cancer index improved, it goes to the upper arm to complete cytoreduction, then to complete the surgery. This is also the same almost for synchronous peritoneal metastases. Another era is now for the circulating DNA cells, because the number of circulating or the percent confirms the severity of the disease, and in these cases they are going to use more powerful drugs, and they might change the time of and the duration of chemotherapy. These are some of the cases we did in Egypt. We first opened the peritoneum to see what is going on. If there is involvement of the route of mesentery, or involvement of both ureters, or involvement of multiple segments of a small intestine, we close. And these cases of pseudomyxoma peritonei, also this is omental cake, and different types of dissection. Some of the cases we did to them para-aortic dissection, and of course we remove the omentum and the peritoneum. Sometimes total colectomy, and this is the pelvis after removal of the lymph nodes and removal of the pelvis peritoneum. We can see the iliac vessels and the genitofemoral nerve, and this is the leaflet of the peritoneum we remove, and this is the specimen in one of the cases, and this is the omentum and the tumors, and this is the capsule of the liver completely stripped, and the diaphragm is up there, and here is the capsule also of the liver stripped. Our experience in Egypt, we have in Egypt about 8 devices for HIPEC, 4 in the government and the university hospital, and 4 private ones. Our experience, 39 patients, open technique, and 42 males, 22 females, 24 cases primary surgery, 40 recurrent cases, 27 rectosigmoid, 13 transverse. And the operations entailed sigmoid proctectomy or total colectomy, right hemicolectomy, other organs removed, gallbladder, ovaries, partial cystectomy, small intestine, partial gastrectomy, ureter, pelvic nodal dissection. Complications, most of them were, the most serious are intestinal fistula. And this is usually causes severe morbidity and may lead to mortality. Other complications which happened, bladder injury, ureteric injury, duodenal injury, pleural tear, complications like DVT, pulmonary complications, etc. And the post-operative morbidity was DVT 4 patients, intestinal fistula in 9 patients, chest complication, follow-up period between 2 months and 52 months, 16 living with recurrence, 36 free of disease, 12 died during the follow-up. Outcomes, 5-year overall survival, 52%, 5-year free survival, 37%. Conclusion, colorectal peritoneal metastases is a clinical problem in practice, require evaluation and management by specialized centers and specialized surgeons. Attention to proper patient selection will give good results. At first, we started with bad cases and high peritoneal cancer index, which had good high percentage of morbidity and mortality, but now we select the cases which will benefit of this technique. Thank you.
Dr. Jamal, you have another paper you will present, or you can take rest if you would like. Yes, present it now. Just you have paper of Dr. Jamal about resection of irresectable colorectal cancer. Dr. Jamal is Emeritus Professor of Oncology. Please, Dr. Jamal.
Shall I? Second presentation.
Third.
Second presentation, please.
Yes. لا هي تسلسلها الثالث.
Number 3.
يقدم اثنين.
ايه. Number 3. يقدمها ليش يقعد يستنى؟
تمام. You did the best.
Yeah.
Number 3.
Resection.
Resection of
irresectable
colorectal cancer.
No title? Just number? Number 3.
Yes. Go to the second slide. Yes.
Yes.
My talk will be about resection of the irresectable and locally advanced or recurrent colorectal cancer. We mean by irresectable, locally advanced or multivisceral involvement, or cases that received chemotherapy and radiotherapy and failed to respond and present with multivisceral organ involvement. Usually it is used for locally advanced primary and recurrent cancer rectum, and this is the only chance for cure for these patients, miserable patients. Invasion of adjacent organs occur in 10 to 20% of patients suffering from colorectal cancer. Long and short-term results are due only to surgical resection. Aggressive surgical concept, pre- and post-operative systemic treatment are the way to produce good results. The decision of multivisceral resection is often made intraoperatively by the surgeon when he opens the abdomen and checks the organs involved, and he decides that he is able to remove them without complication or with the least complication. Multivisceral resection is in the block resection of the tumor and the adjacent organs, may involve small intestine, urinary organs, genital organs, and it should achieve complete macroscopic resection. Adherence of the primary or recurrent tumor is a problem because we can't decide whether this adherence is due to inflammation or due to invasion. But we should consider all these cases where adherent organs are present. We consider them metastatic or locally spreading, and we deal with them by complete excision safely. 60% of cases of postoperatively classified as inflammatory adhesions. And the lysis of adhesions may cause catastrophe if it is malignant. So palliative multivisceral resection for obstruction or fistula and pain should be used on limited ground. Do only curative multivisceral resection. This is a study to see the impact of multivisceral resection and adjuvant therapy in locally advanced and colon cancer. Here, they studied cases of T3 and T4 cases. Some of them were exposed to non-visceral resection and some exposed to visceral resection. And we can see here in the curve for overall survival adjusted. The first one above is for T3, which we did multivisceral resection, followed by T3, which we did no visceral resection, followed by T4. T4 means involvement of other organs, where we did visceral resection, and the last and least survival is, of course, T4, which we don't achieve visceral resection. Also, the disease-specific survival adjusted, this is due to the disease. The survival here is due to the disease. The first up is T3A, which undergone complete visceral resection, followed here by T4. T4 here in the second, which we removed the multiviscera, had better result than T3. Perhaps because these cases, advanced cases, received multiple courses of chemotherapy rather than T3. So sometimes we have better results of T4 than T3. And also here, for the disease-free survival adjusted, the only worst of them was T4, which undergone no visceral resection. The other three were almost the same. So increased survival rates after local multivisceral resection is achieved. The vast majority of the patients with local advanced colon cancer do not receive an extended resection because it is usually have a high incidence of complication, and many surgeons refrain from doing such advanced surgery. Macroscopic or microscopic R0, of course it matters. R0 we mean we leave no residual. R1 we leave minimal residual, and R2 we leave gross residual. In all the studies, R0 have better results. Virtually, surgeons cannot differentiate between inflammatory and true malignant adhesions. That's why we advise and we always say to remove the organ if it is attached to cancer organ involved by cancer. We should remove both, or at least achieve a good safety margin. So every adhesion must be considered malignant, and multivisceral resection is the standard. Data on intraoperative lysis of adhesion to the primary tumor, which prove malignant by histological examination, revealed devastating overall when not performed, with recurrence of 23 to 77%. Not only malignant infiltration in adhesion, but the presence of other tumors perhaps behind the adhesions. Other prognostic factors like lymph node involvement are of paramount importance. This is meta-analysis of Naderzad, which revised 3,000 cases of multivisceral resection, and for patients with locally advanced gastric, colon, or pancreatic cancer, he found 24% for cases of gastric cancer, and for colon cancer it was about 37%, and the rate of morbidity was high. So multivisceral resection is potentially a beneficial procedure, especially there is possibility of curative resection if we did it properly. These are some of the curves to show the relation between node negative and positive in these cases, and resection, type of resection, depth of tumor involvement. Another contradictory result was found by another study by Oliver Beetz, where he found no relation between type of adhesion and survival in one group of 1,200 patients. He found no effect of the adhesions. So multivisceral resection for abdominal tumors can be done also on neuroendocrine tumors, gastrointestinal, locally advanced pancreatic and colorectal cancer. And this is the overall survival according to R1 or R0. These are also some cases of re-resection or advanced cancer rectum. We did 47 locally advanced cases from February 2016 to 2021, 2 groups. One group which entails 16 patients and it was palliative surgery. Group 2 divided into 2. First group underwent ultra-major radical resection after neoadjuvant chemotherapy, and the other was direct surgery. These are some of the cases again. I will show you some video. This is a case of carcinoma of right colon attached to the psoas major muscle. And this is the case of carcinoma of the splenic flexure invading the spleen, the stomach. We see the bile and the pancreas and the left suprarenal and the diaphragm. And we could achieve R0 resection by removing part of the stomach and left hemicolectomy. And this is the pancreas, part of the body of the pancreas and tail, and the spleen. And this is the upper left colic vessels. And of course, we have to explore the kidney and the left ureter. And this is, we removed the whole tumor. We can see the spleen and the rest of the organs, pancreas, stomach, etc. And we reconstructed the bowel and repaired the stomach. And the patient went in a good shape. This is the part of the colon removed. This is a case of right hemicolectomy with part of the duodenum and the psoas major muscle and part of small intestine. Here we separate the right side of the colon and we expose the kidney, of course, and ureter, and we can see here the right side of the pelvis empty, and we have done also pelvic nodal dissection. And we expose the iliac vessels, of course. We can see the iliac vessels here. And we performed right hemicolectomy as well. The results, 8 patients of group 1 experienced further tumor progression and needed secondary palliative procedure. For group 2, in the subgroup A, younger patients had better survival and associated with longer median survival. Subgroup B showed significant longer median survival. A potentially curative resection was possible in 80% of patients. Histological infiltration to the adjacent organs was in 44%, and the other was inflammatory. Conclusion, multivisceral resection for locally advanced colon cancer is potentially safe, statistical significant of long-term survival benefit after multivisceral resection. Every effort should be to achieve complete tumor resection. This is the global curriculum group of the American and European, and me represented African and North Mediterranean. Thank you.
Shukran. Thank you, Professor Jamal. And a question after the meeting, inshallah. Please.
The presentation now will be by Dr. Lawin Shahab Dohoki, rebleeding from duodenal ulcer after primary
تمام.
endoscopic
في
intervention.
فيلم ما جايش مش عارف ليه.
Dr. Lawin is a young active gastroenterologist
اتفضل.
in the Hook GIT Center, and he is a lecturer in College of Medicine, the Hook University.
Tell him
15
the time.
Yes, I will tell him. Just
أو تشتكي
كلهم تعبانين خطي. Stick on time, 15 minutes. Only 15 minutes.
Good afternoon. Thank you so much for the organizing committee. I'm very glad to be one of the speakers for today's event. I'll try to stick to the time. My presentation is about the case of rebleeding after endoscopic intervention. The agenda of my talk. تمام. خارج. ليه أبو دكتور؟ Okay. So the agenda of my talk will be about review of bleeding ulcer, then the evolution of the non-bleeding visible vessel. We will have a case discussion and finally make some conclusions. You know, bleeding from duodenal ulcer is beyond the scope of my presentation. So I'll just make a quick review about the type of ulcer and the risk of rebleeding. As all of you know, that endoscopic appearance of the ulcer gives us an important idea about the risk of rebleeding. So back in 1974, Forrest have made the classification, and now we can categorize the ulcers into two main parts. The first are the high-risk ulcer, which they are called high-risk because they are liable for continuous bleeding or rebleeding shortly. So they include Forrest 1, whether it's an oozing or spurting vessel, the non-bleeding visible vessel, or ulcers with a large clot at their base. On the other hand, we have the low-risk ulcer, which include a relatively benign one because the risk of rebleeding is very low. And they include 2C and Forrest 3, which is an ulcer with a clean base. What about the risk of rebleeding? If we take a look at, I'm sorry, there's something missing. Anyway, the risk of rebleeding from an ulcer with a large clot is below 30. The risk of rebleeding from an unbleeding visible vessel is half, so half of them will rebleed. And those with active bleeding, around 90% will rebleed. So I will concentrate from now on ulcer with an unbleeding visible vessel. There was a nice paper back in 2004, and they did a very nice study in which they do endoscopy on a daily basis on patients with active bleeding. And what they found, that patients who have an unbleeding visible vessel, which can be defined as any patient who's having an ulcer with a protuberance but not an active bleeding, well, those patients were followed up daily, and within nearly 7 to 8 days, this protuberance without intervention will go and become a thrombus, and finally there will be formation of what we call it a sentinel clot. So patients with sentinel clot are very unlikely to rebleed. However, this is not the case in all patients, and you might not see this chronology of the events in all patients with non-bleeding visible vessel. So the risk of rebleeding in patient with non-bleeding visible vessel depends on the size of the ulcer and the of the vessel and the location of the vessel within the ulcer. As all of you know, and all the endoscopists face, that usually the commonest type or the color of the non-bleeding visible vessel is the red, followed by the dark, by the black, and finally the whitish. However, the whitish one are actually the most risky for rebleeding because they usually represent early fibrin deposition. As you know, because it's the bleeding, the non-bleeding visible vessel is just a transient, represent a transient phase of ulcer healing from the active bleeding into the clean base ulcer. So let's move to the case. The case was a 49-year-old man. He presented to our emergency department after 2 episodes of dizziness and sweating, shortly following passing of 3 motions of tarry stools. When I saw him back before 2 months, he was uncomfortable at that time with tachycardia, postural hypotension. On examination, he showed no signs of portal hypertension. The respiratory examination were normal. We sent him for a couple of investigations. However, just his past history was unremarkable, but he was taking a daily aspirin as a primary prophylactic measure, 100 milligram. So from this history and examination, we assume that we are facing a case of an acute non-varicella upper GI bleeding. We treated him with normal saline, IV proton pump inhibitor. His hemoglobin came back 10.2. The blood urea was 86. The renal and liver synthetic function were normal. And we calculated his Glasgow-Blatchford score, which was 10. And actually, the Glasgow was firstly introduced just to help the health authorities to determine which patients would need an urgent endoscopy from those who can be managed as an outpatient. But then it has been validated, and they saw that patients with higher risk of Glasgow-Blatchford score are more likely to rebleed and will have a higher mortality. So any patient with Glasgow more than 10 usually indicates a severe bleeding. Since we see that the patient has postural hypotension, we gave him 1 unit of packed RBC. We kept him nil by mouth and prepare the endoscopy for him. You can play, please. So this is the endoscopy. Here we are in the first part of the duodenum. As you see, there is, it might not be clear, there were multiple ulcers at the antrum. All of them were clean base, but this ulcer, which I thought was the culprit one, it showed a visible vessel in its center. The ulcer was located at the posterior wall of this bulb with some extension to the superior part. So we decided, you know, there are many methods of intervention. Many of them have their pros, have their cons. But my approach for this case was with dual therapy, applying clip and then adrenaline injection. Fast forward, please. باقي وبوش بس دقيقة هستا بس فوسفور أخيراك أوكي أوكي إيه أو هذا سرا أوكي تمام okay. So these are multiple ulcer at the antrum. On retroflexion there was nothing remarkable. هال فيرا بدا أوا ببا ليرا كليكيا تمام ده دي بروكا إننا ببا فوسفور دي تمام أي أوكي نانا تو كليكيا تو كليكيا نمن أي تمام إيش تببا بله دی ببا کاگه دی ببا خودش ترازی پیش تا سوازره هیچ پیچه کدی پیش تر زحمت نبید ده توانی هر 10 second 15 seconds تمام ده سریع بچینه همین تو واسطه اینا فقیره so okay 10 more. So here we open the clip. Okay, we can shift to the next video. I will shift it. Okay, play Zahman Navid. So we applied the first clip. And I think that the result was good. But we always try to seal both sides of the feeding artery. I decided to put another 2 clips to make it more secure. Pichek fast forward because Ahmed Navid. تمام. ايش ده؟ توزكتر. تمام. You know, sometimes we're in the duodenum, and especially when you deal with an ulcer of a fibrotic base, it's difficult to stabilize the scope, and you won't get the freedom to manipulate with the prongs of the clips. ايش ببا؟ بله. So we applied second clip. ببا. And I just wanted to put the clip above both of these two to make it more secure. ايش ببا؟ باش ببا. بله. ايش ببا؟ ايش the third clip was actually it was like an overshooting. We didn't get into the ulcer. So after we finished, we injected with adrenaline around 8 cc. The rapid urease test was positive. We admitted the patient for 48 hours, kept him nil by mouth, and put him on IV PPI, and followed them in the hospital. And we follow the patient clinically, and in the next 48 hours, he has become stabilized and show no clinical nor biochemical evidence of rebleeding. So the patient was discharged home on oral PPI. His discharge parameters were all within normal. However, several days later, and actually in the 9th day, the patient called us back. He presented with signs of rebleeding, as evidenced by the presence by the history of the patient that he developed another attacks of melena. When we saw him back, he showed signs of bleeding. In terms of tachycardia, again, hypotension. We started from the beginning. We treated him as a case of free bleeding. We assume as a case of free bleeding until the endoscopy confirmation. And we gave him another unit of packed RBC. His Glasgow has even increased further in his second episode. And this is his second endoscopy. So if you see that we are in the same area, probably the same visible vessel. Fast forward, tamam. See, there is a red and very apparent visible vessel. You see that both our clips have been dislodged, and the clip which was inadvertently we put in was present. So this clip was actually non-functioning, and it was like an overshooting, which is common in patients with when applying clip. So again, at this time, I decided to do adrenaline injection before applying clip. Fast forward because Ahmed Nabi. Hesh. And after injecting adrenaline, usually try to put the visible vessel between the center of the prong of the clips and apply the clip. And I think that at least the early endoscopic picture was satisfactory. Again, we admit the patient and keep him for 3 days, and fortunately, this time he went back. So what's going on? This is a case of free bleeding from the non-bleeding visible vessel. And actually, when you search on the net for how to manage, how to approach the patients of free bleeding, what about the incidence, the papers are scarce. So typically occur in the first 3 days, but however, as in our patient, just 3% will be delayed for 8 to 14 days. The risk factor are the initial presentation of hematemesis, blood retention during endoscopy, shock state. If you give more than 500 cc RBC, if the admission hemoglobin is below 10, if the ulcer size is large, and if the exposed length of the non-bleeding visible vessel is more than 3 millimeter, or if it is a white. And of course the location, as in our case. So I think that our patient had shock. He had an ulcer relatively, if you measure the surrounding tissue of edema or the inflammation, it's around 2 centimeter, and the location was actually a little bit difficult. So my take-home notes will be, with the recent endoscopes, that it's now easier to characterize the lesion or the ulcer, and this will help us to predict their future risk of rebleeding. The rebleeding, as in our case, can be delayed. It's not always short or just in the first 3 days. And dual endoscopic therapy have been, and there is many debate on this point, but it's still preferred over the monotherapy. And we should always be aware of the risk factor. So this is we did the endoscopy after 8 weeks. Best fast forward because Ahmed Nabi. Just let me show you what happened to the visible vessel. Fast forward again. تمام بلاي كده سريع بقى تمام ايش سريع ايش oh, this is the site of the ulcer. Just this is a dimple that represent the bleeding, the bleeding from the non-bleeding visible vessel. It's here. And there is barely a scar, thankfully. Thank you so much.
Please, there is a proverb, if speech is gold, silence is, if speech is silver, silence is gold. Please keep silence. ضروري. I think there is an effect on the speaker. You can present the speaker.
Yes, I can. Bismillah ar-Rahman ar-Rahim. I am Dr. Jamal Gailani, General Surgeon from Erbil. I want to present your next speaker, our colleague, friendly colleague, Mohammed Niazi, Ghani, he's a consultant surgeon, gastrointestinal and hepatology surgeon, director of training in Kurdistan GI surgery subspecialty in the Zgari Teaching Hospital. He will present a case, reporting case. I think this case is really it is not only the job of a surgeon, maybe also it is one of the jobs of the orthopedic surgeon. But he will speak about his efforts in the extraskeletal pancreatic Ewing sarcoma as a case report. Your time, Dr. Mohammed, is around 15 minutes. The mic is open for you.
Good afternoon. It's my pleasure to share with you a rare case with a typical presentation, extraskeletal pancreatic Ewing sarcoma, as a case report. Ewing sarcoma is a malignant osteolytic tumor characterized as a small round cell tumor, was first documented by James Ewing in the 1921 as diffuse endothelioma of bone. Extraosseous form of Ewing sarcoma was first described by Taft in 1969. Ewing sarcoma is a family of tumor, including classic Ewing sarcoma osseous origin, atypical Ewing sarcoma extraosseous, and primitive neuroectodermal tumor, Askin tumor. All these tumors have common morphology, immunological features, and cytological and cytogenetic, hence including in the same family of tumor. The primitive cell can be either from the neural crest or mesenchymal stem cell, but the definitive cell is till now not determined. Ewing sarcoma occurred due to cytogenetic alteration in 1122 translocation, which led to the formation of the fusion protein FLY1. Osseous Ewing sarcoma is more commonly found in the diaphysis of long bones and extremely rarely occur as an extraosseous. Reported to arise from extraosseous Ewing sarcoma reported to arise from solid organ like lung, gallbladder, kidney, urinary bladder, uterus, and vagina, and very, very extremely rarely occur in the pancreas. Mostly reported in the second decade of life with equal in male and female. It is an aggressive tumor with unavoidable multiple recurrence and relatively poor prognosis. The tumor can be easily misdiagnosed for different tumor due to lack of established diagnostic pathological criteria, hence in the case of pancreatic tumor. But the chemotherapy combined with surgery showed relatively better outcome with 5-year survival rate of about 80%. The pancreas is an extremely uncommon extraosseous location with only 33 cases reported in the literature. My case was a 13 years boy present to me in the March 2019 as an epigastric pain, severe epigastric pain associated with vomiting, mild fever, tender abdomen for 1 week. The lab, there was a history of trauma as he was playing football too much. The blood tests show hemoglobin 10, white blood cell 14. Other blood tests, renal function was normal. The CT showed that there is a mass with central necrosis connecting to the stomach, suggesting gastrointestinal stromal tumor. The OGD showing no mass in the stomach, just a bulging causing an obstruction. So we decided to do a surgery as the radiology was suspecting the mass. We did surgery. Intraoperative finding was other thing. There was a cystic mass in the body and tail of the pancreas containing infected fluid adhered to the posterior wall of the stomach, with inflamed pancreas. So we did cystogastrostomy after taking a biopsy from the wall and the fluid for the cytology and culture sensitivity. The cytology revealed normal, no malignant cell, and the culture sensitivity bacterial infection. But the histopathological examination was pancreatic pseudocyst. So the diagnosis is a pancreatic pseudocyst. Follow-up of the patient with ultrasound after become better, no pain, no any complaint. The cyst was decreasing in size till 5 months post-op, complete recover. Ultrasound show no any cyst. 2 months later, after this 5 months, it means 7 months, the patient returned to me with a mild epigastric pain, somewhat continuous and aggravated with meal, and the ultrasound show 4 cm, pancreatic pseudocyst, and with the gallstone. Previously, there was no gallstone. CT showing large, well-defined, non-enhancing pancreatic cyst with internal debris. Also, the radiologist regard it as a pseudo-pancreatic cyst. 9 months post-surgery, on follow-up, we repeated ultrasound show multiloculated hypoechoic collection, about 7 by 5 cm, normal pancreas. MRCP and MRI show no connection to the main pancreatic duct, and the cyst was not containing any mass or solid component. So I asked to do an EUS, but the family refused it, as at that time we was not having EUS in our city. And because of the city, 7 months post-op, and the MRI and MRCP of the cyst, multilobulated cyst. Due to COVID-19 pandemic, the patient disappeared. Till become 1 year post first surgery. Returning as the pain, epigastric pain recur, and ultrasound showing gallstone, pancreatic pseudocyst, no solid component, and same size at the 9 months. So we decide to do surgery, the procedure cholecystectomy and Roux-en-Y cystogenostomy and biopsy from the cyst. I was suspicious about the cyst, but no one with me to do definitive surgery, as there was no worry sign in this cyst, a solid component, and the patient was young, 13 years old. And there was no frozen section at that time, as I asked to do it intraoperatively, but because of COVID-19, nothing was present. The histopathology returned to me as poorly differentiated carcinoma, suspect neuroendocrine tumor. And the cytologic cystic fluid was high CA, LDH, and amylase. So I did a CT staging to see an extra pancreatic metastasis. There was no any metastasis. Just this CT saying that there is thick irregular inner wall cystic mass measuring 5.3 by 5.9 cm at the region of the tail and distal body with enhancing nodular solid component and no metastasis, even no lymph node near to the cyst. After consultation of the oncologist, he asked me to do surgery if it is resectable, then adjuvant chemotherapy. It was resectable, so I did the third surgery within 1 week to 10 days, like that. The procedure, distal pancreatectomy with partial gastrectomy and splenectomy. The specimen. Histopathologic examination, poorly differentiated neuroendocrine tumor at the first time. This is the 5 to 10% of the tumor showing granular cytoplasmic staining for synaptosis and CD56, while about 10 to 15% showing nuclear staining. But the immunohistochemistry showing other thing, that it is an extraskeletal Ewing sarcoma, not neuroendocrine tumor. Due to this presentation in the cytology, which regarding this all immunohistochemistries, if not present conclusively excluding neuroendocrine carcinoma, the conclusion was high-grade malignant pancreatic neoplasm with morphologically and immunohistochemical features of sarcoma. So the case regarded as extraskeletal Ewing sarcoma, which is a rare case, is the CD99 one of immunohistochemical staining showed diffuse membranous staining, but the very important is the FLY1 staining, which regarded as a Ewing sarcoma, showed nuclear staining. This is the pancreatic duct, benign ductal gland, and this is the malignant small blue cell. The oncologist start chemotherapy, VAC, vincristine, adriamycin, cyclophosphamide, plus IE, ifosfamide and etoposide, for 8 cycles instead of 17. Because of upper GIT bleeding and hemoptysis, the oncologist stopped the chemotherapy until the patient recovered from this complication. After controlling complications, the patient became better, but refused more chemotherapy. So the oncologist did a PET scan to see if there is remnant or not. The PET scan showing a nodular lesion closely related to the distal aspect of pancreatic remnant along the surgical suture. It was a recurrence 6 months post last surgery. Oncologist's decision was to start stereotactic radiosurgery, which done outside the country. After that, the patient became completely cured with no radiological finding of the mass and laboratory. Till 2 years post-surgery, until now, he is okay with no recurrence. From the literature view, this article showing a 24 patient with extraskeletal pancreatic Ewing sarcoma. Most of them, the presentation, abdominal pain, vomiting, mild fever, jaundice, like that. Most of them in the head of the pancreas, not in the tail. About more than 15 cases in the head of the pancreas, less than 3 cases in the tail and body of the pancreas. It's not clear. The conclusion, Ewing sarcoma of the pancreas is a rare, but should be put in consideration of differential diagnosis of pancreatic lesion. In terms of recurrent pancreatic cirrhosis, EUS is important for tissue biopsy and fluid analysis. And intraoperative frozen section for the cyst wall in recurrent pancreatic cirrhosis is also mandatory to exclude carcinoma if EUS biopsy is inconclusive and no radiological sign of malignancy. Thanks.
شكرا. I may call Dr. Serdar Hassan Arif. The wave of COVID was escaping, but she left a number of our colleagues in gastroenterology died as a result of COVID. And even in Kurdistan, Dr. Tayyib, alayhi rahma, he died because of COVID.
You wanted?
Good afternoon. Thank you, Mr. Chairman. My presentation, we will concentrate about what happened last years about pandemic of corona, COVID-19.
Sharing this study article with my colleague, Dr. Ayad Ahmed and Dr. Reber Haji from University of Duhok. There is no conflict of interest to disclose. So, as we know, the novel COVID virus caused a major pandemic and major health crisis because of its high infectivity. It is mostly caused respiratory involvement ranging from mild respiratory symptoms to major lung involvement with fibrosis and respiratory failure. And GIT manifestations were reported in up to 40% of patients infected with COVID. And they range from mild and non-specific symptoms such as anorexia, loss of taste and nausea, vomiting, diarrhea, and abdominal pain to a more serious presentation like bleeding and ischemia of the bowel. The involvement of GIT system in patients with COVID is mediated by the expression of the ACE2 receptor by the GIT cells. Viral binding occurred to the mucosal cells due to high affinity to receptor binding domains. And the prognosis of patients with GIT involvement is largely unknown. Some studies suggest that patients with severe GIT involvement have unfavorable prognosis and have higher rate of complication than other patients. The aim of our study to describe the various GIT manifestation and types of intervention and outcomes of patients with COVID infection. So this was a retrospective cross-sectional study between 2021 to 2022 on 301 patients who were diagnosed with COVID infection and who had GIT complaint were included in this study. The epidemiologic and clinical laboratory radiological characters and treatment outcomes were obtained from medical record of patient directly. The results in our study, the average age was 50 years, and it is more in male, our case is more male than female, 168 male. And the time between presentation after COVID diagnosis and between the presentation of GIT and COVID diagnosis was average 19 days. Regarding the symptoms, GIT, different clinical presentation, abdominal pain, most of cases there was no abdominal pain, no abdominal pain, 147 cases. But if there was abdominal pain, it was generalized abdominal pain in 78 cases, 25%. Then epigastric pain, 19%. We have other GIT complaints. In most 68% patients, no other complaint. And we have diarrhea is 92 in 92 cases. We have melena, 32 cases, and other bloody diarrhea in 29 cases. And non-GIT complaint in 150 cases. Regarding, I will not go in detail about these investigations. COVID was positive PCR in 295. The other test, IgG, IgM also, this is the range. And white BC, it was elevated in average 11,000. And CRP, of course, elevated. D-dimer was elevated in these cases in average 2,081. And also serum ferritin and interleukin. Regarding the imaging studies, most of cases no imaging study done, 78%. Some of cases we underwent CT or ultrasound, X-ray, or multiple imaging modality. Regarding intervention, no intervention in 47 cases. We have upper GIT, most common upper GIT endoscopy done in 31%, and colonoscopy 11% of cases, and surgical intervention in 30%. Regarding the diagnosis, non-specific diagnosis in 122, and we have gastritis and duodenitis was the most common diagnosis upper GIT complication. Also peptic ulcer and bleeding, and cases pancreatitis, even perforated appendix, distal ileitis. We had, regarding the procedure which and were done for these cases, we have conservative management of most of the cases, bowel resection done in 16 cases, laparoscopic cholecystectomy done for 5 cases, and suturing of peptic ulcer bleeding in 3 cases. Even splenectomy 1 case, pancreatic necrosectomy in 1 case, and most of bleeding stopped by endoscopic adrenaline injection in those cases with bleeding. And regarding the complications, most of cases there reveal no complication later on. Death occur in 11 cases of these 301. Guillain-Barré syndrome developed in 1 case and wound infection in another case. Most of, you see, most of cases improved, fortunately 96% improvement, but 3.6 mortality. So the discussion, the extrapulmonary symptoms are reported in many patients, such as gastrointestinal presentation like anorexia, nausea, vomiting, diarrhea, and some other emergency presentations, such as bowel ischemia, and even gastrointestinal emergencies. Other severe GIT complications included extensive hepatic necrosis, acute acalculous cholecystitis, and bowel ischemia. And many studies reported the high gastrointestinal complication rate in severely affected patients. Some studies suggest that the female are more liable to develop GIT complication, although this is not supported by many studies. In our study, male patients contributed to the majority of these cases, 55%. And the mean time of presentation infection was 19 days. Regarding abdominal pain was presented in 51% of cases. As I said, most of them was generalized abdominal pain, other epigastric pain in 19% of cases. And although abdominal pain was reported with less frequency than out study in some meta-analysis, in patients with abdominal pain, the severity and the site of abdominal pain may give a clue about the possible pathology. An important cause of abdominal pain included pancreatitis, appendicitis, cholecystitis, and bowel ischemia, and some other causes. So the next presentation was diarrhea, was the second most common presentation in our patients, 30% after abdominal pain, followed by melena in 10%. Bloody diarrhea or bleeding perirectum were seen in 9% of cases. Most patients reported to have a low volume to moderate volume diarrhea. In some studies reported that up to 50% of cases, patient has diarrhea and was lasting for an average time of 5 days and relieved a mean time of 13 days. Anorexia and vomiting were reported in 6% and 5% respectively, and diarrhea and vomiting were reported in 4.3%. Also, anorexia is reported in around 25% of cases. Loss of the taste in 1 case was reported in our study. Bloody diarrhea was reported in 9% of cases, and hematemesis and melena in 1% of cases. Should know 42.8% of cases underwent upper and lower GIT endoscopy. It is reported that these presentations are more common in patients with severe GIT manifestation. Most of the affected patients have mild disease at time of presentation, and the mean IgG and IgM level was 7 and 4 respectively. And inflammatory marker also increased, like other studies, no difference. Although D-dimer is not a specific, indicator of the inflammatory, but it may predict an increased risk of thromboembolism events. The majority of patients did not require any imaging studies, and about 31% of our cases require upper GIT endoscopy, and as I said, 11 colonoscopy. although this colonoscopy should follow a standard guidelines for consider when it is very essential reach the diagnosis. The virus can be isolated from the saliva and the GIT mucosa, and this precludes the use of specific persuasions to have a good infection control. The mechanism of erosion may be attributed to drugs that patients take, which may result in gastric and esophageal erosions, such as non-steroidal anti-inflammatory drugs. Herpes virus also has been isolated from an ulcer in some patients. The majority of patients were treated conservatively in our study with good hydration, analgesia, antiemetics, supplement, and good oxygenation. Non-steroidal must be restricted, and other measures depending on the system which involved. Patients with severe manifestation require a multidisciplinary team, critical care specialists, physicians, surgeons, nutritionists, and gastroenterologists. And surgical intervention reported for cases with intestinal obstruction and bowel ischemia, acute appendicitis, and some cases of severe bleeding. Bowel ischemia is mostly attributed to coagulopathy or vasculopathy, which increase the thromboembolic events. In our study, 9% of patients, 28 patients require surgical intervention. 16 of our patients require segmental small or large bowel resection. 11 of them had small bowel ischemia, and they require emergency laparotomy and the resection of the affected segment of bowel, and rest of them for intractable large bowel or rectal, even case rectal bleeding. Bowel ischemia should be suspected in such patients with severe abdominal pain and sign of intestinal obstruction. And the use of anticoagulant should be started early in such cases. Patients with GIT bleeding will require endoscopic intervention, clipping, cauterization, and successful in managing bleeding in most of cases. So in this study, 47 patients present with upper GIT bleeding. 25 patients require endoscopic intervention to stop the bleeding. 3 patients required open surgery to suture the bleeding site. And most of cases, many of cases managed conservatively. Gastritis and duodenitis was the diagnosis in 49% 9 cases and treated conservatively. On patient required colonoscopy, 8 patients were diagnosed with terminal ileitis, 29 patients were diagnosed as colitis or proctitis, or colonic or rectal ulceration and bleeding, and 1 patient with severe rectal bleeding due to large rectal ulcer bleeding in old age patients, and later on he died in intensive care unit from the complication of COVID, pulmonary complication. A closed smoke evacuation filtration system with ultra low particles air filtration capability, similar laparoscopic device during minimal invasive surgery for patient with COVID infection. We learned this during that pandemic, to especially laparoscopic surgery dealing with gases. There is risk of virus transmission, so should adopt such a smoke evacuation filtration system in theater. About 12 patients presented with acalculous cholecystitis and treated conservatively, but 5 of them required laparoscopic cholecystectomy. Other 12 patients were diagnosed as acute pancreatitis. 3 of them required admission, and 1 case required pancreatic necrosectomy. The expression of ACE receptor 2 receptor in pancreatic cells render the pancreas an increased risk of infection by the virus. So the severity of pancreatitis depends on many factors, such as general condition of the patient, immune system status of the patient, and the comorbidity. And most of cases have a mild attack, but some patients develop severe pancreatitis with necrosis, required emergency surgery. Right iliac fossa pain presented, and most of cases was diagnosed as acute appendicitis, also terminal ileitis. And 4 patients of acute appendicitis developed during the disease course and treated with appendectomy. Some study, although reported in that era of COVID, to leave uncomplicated cases of appendicitis conservatively. One of our patients presented during acute stage with sign of shock and without history of abdominal trauma, and by CT scan there was abdominal collection, and during surgery we found a spontaneous rupture of the spleen and splenectomy done for him. There are many types of infection that may cause a spontaneous splenic rupture, like malaria, infectious mononucleosis, some other viral infection, but this is reported in a case with COVID in our case. Most of our cases fortunately improved without intervention. One of case, as I said, developed Guillain-Barré syndrome, and another case developed wound infection after surgery. And the mortality in COVID, it was ranging between 0.6 in pediatric age group to 7.8% in elderly patients. In conclusion, gastrointestinal manifestation in patients with COVID-19, even in absence of respiratory, is common, even in absence of respiratory symptoms. Abdominal pain and diarrhea are very common complaints. The gastritis and duodenitis with ulcer are common, were common endoscopic finding. The use of endoscopy and colonoscopy should follow the guidelines. This is in conclusion. The management of GIT symptoms is mainly supportive unless there are signs of acute abdomen. In such case, a serious and life-threatening cause must be excluded, like bowel gangrene should be excluded. And these are the references, and thank you.
شكرا.
Thank you very much, Dr. Sardar Hassan Arif from Dhok. Our journey is reaching Suleymania, the few last seconds or minutes in this nice KDD conference. The thanks for the committee, organizing committee of this five-star conference. Thanks for the management bodies of this conference. And we are waiting the next speaker from Suleymania. He will speak about updating us for the medical investment in this beautiful city. We are ready to hear his profile about high-quality hospitals, Anwar Sheikh Medical City in Suleymania. The speaker is Kurdo Abdullah Saeed. Welcome.
Good afternoon. My name is Cardo. I am Chief Operative Officer at Anwar Sheikh Medical City. Today I would like to give a brief presentation about our hospital. Our hospital belong to the chain of the hospital, of the high quality hospital, which includes Anwar Sheikh Medical City and Garmian Medical City, Khizmat Medical City, and Jaf Medical Clinic. And inshallah, near future, it will be Rania and Kirkuk Medical City. Our business is based on the three main pillars. The purpose of our business, we strive with passion to meet healthcare need of the people and build healthcare community. While our vision is to be claimed as the most trusted healthcare provider through whole Iraq. And the mission of our hospital is to integrate advanced technology and empowered healthcare team to provide and deliver exceptional patient-centric care. To provide and enhance patient satisfaction and to deliver high-quality service, We provide a lot of, or wide range of the specialty in our hospital, and wide range of the center, diagnostic center, as it is some of these in this slide is to be cleared, like the hematology oncology center, dermatology center, psychiatric center, GIT center, and beside a lot of wide range of the specialty, general surgery, internist, dermatology, oncology, and orthopedics, and etc. And we have the most advanced laboratory analysis and radiology center. Beside that, recently we provide some new services to our hospital, like open heart surgery and ESD and PET scan and neurointervention radiology. And in the near future, we are having some upcoming services, which is like ophthalmology centers, dental center, liver transplant, and gamma ray, and the last one, which is shall be in near future, HIPEC surgery, which is hyperthermic interperitoneal chemotherapy surgery. It will be leading in the Suleymania city. We have many partnerships inside and outside of the Iraq. I will mention some of these partnerships outside of the Iraq: Italy Pediatric Hospital, Gazaline Hospital, and the Metropolitan Hospital in the Greek. And we have some Indian hospital and some hospital from the UAE. And the last, we have the partnership with MNT Center for the Radiology, which is located in Turkey. And the area of the hospital, it's around 13,000 meters square. It's mainly two buildings, hospital building and clinic building. We have more than 12 advanced operation theater. We have more than 10 beds of the ICU. We have an ICU and the wide range of the clinics and center. Thank you so much for your listening.
Thank you very much.
Dr. Kordo, please, you can sit. May I call speakers for question? We allow 2 questions for each speaker, please. Dr. Jamal.
Dr. Sardar.
Laween, Dr. Mohammed, Dr. Sardar, and Kordo with us. Please, you can sit, take a chair.
Welcome. Welcome.
دكتور قهوة أهلا كاتب
مرحبا.
يا الله. Any question for Dr. Jamal? Please. Microphone.
Well done, Jamal. I think it's a fantastic talk. Anybody have done cluster transplantation for these multiple cancers? Evisceration of the bowel and the viscera, and then transplantation. Did anybody do it?
Aye, Dr.
Has anybody done transplantation in this scenario? You do evisceration. You took all the colon, the small bowel, stomach, everything. Evisceration. Did you done cluster transplantation at the same time?
Same time.
We have seen in Germany people doing cluster transplant in such scenarios. None. Okay, thank you.
Sometimes we do liver metastatectomy. Sometimes we do liver metastatectomy if there are liver metastases in the same session. Yes.
Okay. And for the rebleeding, peptic ulcer disease. Sorry, and did you try hemospray? It's a local lesion, no clear bleeding vessel. Did you have hemospray? Hemospray?
Thank you, Sir Dr. Maki. I think hemospray has no role for a non-bleeding visible vessel. Hemospray is mainly used for actively bleeding lesion that cannot be controlled by other modalities like electrotherapy and clipping. But as far as I know, and from the literature, that it has at least not been studied for controlling bleeding or preventing rebleeding from a non-bleeding visible vessel.
This patient you presented is a young man who was on aspirin as a prophylaxis. صح?
Yes, yes.
And there were there's no indication for prophylaxis now below 50, number one. Secondly, the bleeding was diffuse gastric ulcers and duodenal ulcers. It's not localized to the duodenum. It was both duodenal and gastric erosions, yes?
Yes, yes, of course.
You did not demonstrate free bleeding. So I think, and the eclipse by itself, we have a fibrotic duodenum, can cause bleeding, you know it.
Exactly. Yes, you are absolutely.
Coming to the COVID, we have seen
Dr.
Sardar, COVID and the GI. We have seen COVID causing hemiplegia, pericarditis, endocarditis, myocarditis, pancreatitis, hepatitis, and those who has diverticular disease, they got the most worse, especially elderly. With chronic diverticulosis, we have seen 2 deaths.
Yeah.
Chronic diverticulosis and died after COVID.
Yes.
We have seen now, I am following now 4 cases of inflammatory bowel disease on biologics after COVID. And the ASCA was also positive.
Yes.
And your series of those who has bleeding per rectum and the colitis and ileitis,
Yes.
did you follow them for colitis? Because the COVID is a virus.
Yes.
It initiate inflammatory bowel disease,
Yes.
especially those susceptible like ASCA positive.
Yeah.
In your city, did you do any ASCA in your studies?
No, unfortunately, we couldn't follow all these cases for a long time. And we just take a cross-sectional study from our data regarding GIT manifestation. And we take it from the record, medical record.
You know,
But
COVID,
we, maybe,
you know the long COVID
Long COVID,
can
yes.
go for
Yes.
1 year. Presentation can be arthritis, can be skin disease. We have seen severe diseases, allergy, and many deaths from
as a
COVID.
trigger for immune system, yes,
All
autoimmune.
these
So
patients should be
autoimmune
followed.
disease, yes.
All these patients should be followed
Yes,
for
should
the
be
future.
followed.
Thanks very
Yes,
much.
I agree.
أشكرك دكتور مكي. دكتور مكي, during epidemic of COVID, yes, epidemic of COVID virus, we are as physicians, we suspect any fever, any febrile patient, he might be COVID. In surgery, I should consider it during epidemic of COVID, any acute abdomen should be suspected first COVID.
Yes,
You
ischemic bowel.
And we
yes,
saw a lot
most
of
common.
cases, they present with acute abdomen,
Yes.
acute bloody diarrhea, considered as COVID-19.
Yes.
This is the lesson taken from escaping COVID, you know. Thank you. Please, Doctor. تفضل. واحد بيكم.
Thank you, Mr. Chairman. My question to Professor Jamal. Do you recommend HIPIC after your experience, this long experience, or just cytoreductive surgery for these patients with chemotherapy? So you have another question to Dr. Sardar. Shall I ask now or later on?
You can ask it. Ask him. Yes.
Regarding your patient, Dr. Sardar, those who they did cholecystectomy for acalculous cholecystitis, there was clear indication for surgery, or for example, you follow this patient by conservative, failure conservative or not. I think 4 or 5 cases of cholecystectomy. Again, those patients of appendectomy, you discover COVID after appendectomy or before the appendectomy? Because as the doctor said, in this endemic period, you have to think about COVID before appendicitis or other thing. My last question to Dr. Muhammad, why he did gastrostomy in the first operation? It was really pancreatitis. This history of trauma, it was real trauma and caused pancreatitis, and then cirrhosis, And you know, not all seedosis needs interference, and there's criteria, size, time, follow-up, because I think from the beginning, this bypass, this cystogastrostomy, might be not the correct decision. Thank you.
شكرا جزيلا. تفضل دكتور جمال. الميكروفون.
مايك.
As I mentioned, there was criticism for this study because they didn't use mitomycin, which is very effective than oxaliplatin. They used it only for 30 minutes, not for 1 hour or 1 hour 20 minutes. The cases were advanced in the arm of HIPEC with high peritoneal cancer index. So they are going now to repeat studies, as I mentioned, ongoing studies to reach consensus. To myself, I think it might be more beneficial in ovarian cancer because ovarian cancer is primarily a peritoneal disease. It usually spreads along the peritoneum and the omentum more than the colorectum, and I think if you achieve complete cytoreduction, R0, and you join it with HIPEC, I think you might get better results.
Why I'm asking this question? Because in our area, you have till now, you haven't HIPEC. For that reason, I ask you. Thank you very much.
Thank you.
دكتور سردار.
Dr. Diari, you asked about cholecystectomy, acalculus. Most of cases was acalculus, and from 11 cases, only 5 cases we did for them laparoscopic cholecystectomy. The other passed conservatively. But because they resist to treatment and we are afraid from complication of cholecystitis, perforation and empyema, especially emphysematous cholecystitis. Regarding acute appendicitis, most of these cases, you know, the era of COVID, any case admitted to emergency hospital, they suspected COVID, so they did test for them, yani PCR, and yani we know this is case COVID before doing appendicectomy. But when we diagnosed appendicitis, we did for them surgery, yani complicated cases. Yes.
شكرا دكتور دكتور محمد.
دكتور دياري.
تشتغل.
Why I did cystogastrostomy? There was an obstruction, يعني gastric outlet obstruction, repeated vomiting, pain. If you opened a case like that, you should do something drainage for it internally. That's why I did cystogastrostomy.
There was no gross tumor inside the cyst. There was no tumor.
No gross tumor.
So
just inflamed cyst.
So the diagnosis, there was no calcification at all, no bone tissue. No.
It was an acute stage.
Cystogen.
But there was no tissue diagnosed to do definitive surgery at first, as second operation.
Most likely the tumor obstructing the duct. For that reason it recurs.
CT and MRCP not showing any worry sign. The main pancreatic valve was normal, no solid component in the cyst, no something led to do and definitive surgery. And he was a child, 13 years.
Yes.
I didn't suspect, but there was suspicion of tumor.
Because the question and interaction between audience and speaker is the most important aspect of the Congress. I have a question to Professor Dr. Jamal. Why you use hyperthermia? Is the heat increase circulation and vasodilatation? Is this most important?
The hyperthermia enhances the effect of cytotoxic drugs.
Through what?
And it was a finding. Yes, and it also increases the permeability to allow the chemotherapy to penetrate the peritoneal cavity.
Yes.
And it might have a cytotoxic effect as well.
Yes.
The heat itself
Yes.
has cytotoxic effect.
You get overall survival better than without hyperthermic intraperitoneal with the use of standard chemotherapy in your cases?
Actually, we have done several studies in the NCI in Cairo, some of them for ovarian and some for colorectal. For the ovarian, there was no benefit.
Yes.
It was equal, systemic
Yes.
versus in about 41 cases.
Yes.
In the colorectal, we found better for high peak, but the number is, of course, I think it was 61 cases, cannot give sound decision.
Yes, أشكرك. Thank you very much. I have a question to Dr. Cordo. Dr. Cordo is we congratulate you and the Kurdistan for this nice hospital. The problem in Iraq about hospital, we have no proper university hospital. All university, all over Iraq, even in Kurdistan. We need a proper university hospital, which each teach medical faculty or teaching medical city or medical unit. We need a proper hospital. A lot of private colleges without hospitals. Please, you can allow, we have in Kurdistan, medical education is highly qualified in Kurdistan, I know. And we have a postgraduate and undergraduate. Postgraduate, we have 3 important centers, Kurdistan and Iraqi board. As we have Dr. Sardar, he is the director of the center in Dohuk. Please, you can allow for medical student in, because you see your aspect of the hospitals. You didn't mention about the education. This is highly important.
We are already collaborating with the University of the Medical University of the Suleimaniya right now, and we are collaborating with some private university in Suleimaniya, and we are ready for any other collaboration with any other parts of the universities, and we are ready for service.
My last question to Dr. about the GIT bleeding, Dr. Alwin. Which intervention, endoscopic intervention, associated with more rebleeding? Which of these interventions you mentioned?
This is a difficult question, actually, but
because we make a study.
Yes. You know, Doctor, as I said, all of them have their pros and cons. They haven't been studied, which is more likely to rebleed after intervention. Yes. But I think the results are comparable. Although there was in the last few years, there have the interest to use the monopolar soft coagulation. If you listen to the Dr. Hiwa's session, the ESD, when they did the ESD, once they developed bleeding, they asked the technician to change to soft coag. So soft coag is now gaining attention and is used just to control bleeding. So I would say soft coagulation, soft electrocoagulation, yes, is associated with less rebleeding, even more effective than APC and even clips. Yes.
شكرا جزيلا. No question? Yes, Dr. Sardar.
It collected from many doctors, admitted under their name. So may the doctor, each doctor know his patient, yes. May he doing follow-up. But this is cross-sectional study on the medical record just to collect GIT manifestation and complication. Yes.
كافي. اي استنى وقت يخلص. يلا شكرا جزيلا. نشكركم شكرا لان الاستاذ عمر محمد اخبرني على الوقت هنا تايم. فلا عندك ان شاء الله بعد الميتنج you can talk with any of us about the question. Thank you very much. يمكن راح اتحدث بالعربي حتى اعبر عن شكري وتقديري يكون مفهوم اكثر in our language لان انتم اخواننا الاكراد الموجودين تفهمون اللغه هنا. نشعر من القلب بفرح عظيم لهذا المؤتمر حققت بالجي اي تي، يعني مقارنه مع المؤتمرات الجي اي تي اللي حدثت في السليمانيه وفي هولير في اربيل. يمكن هذا المؤتمر حقق النتيجه المطلوبه في الجاستروانترولوجي. اتمنى كل التطور لهذا البلد ولكردستان العراق وفي كافه الامور. احنا يهمنا صحه المريض، يهمنا التقدم الصحي للمريض. وشكرا جزيلا لكل الاخوان. محمد انك اشكرك. شكرا جزيلا شكرا جزيلا.
في سيرتيفيكيت فور يو اذا صعب عليك البتاع تبقى جنابك. كرسي ابو الدكتور داني اللي رابع دانيشه، كرسي كمان ابو داني اللي رابع. حبيبي شرفتنا، استريح.
استنى.
تفضل استريحنا حتى ما تنزل. دوري مخرة خۆشەویستان بەشی کۆتایی لە ئاهەنگەکەمان I regarded really as a party. ئەم بەشەی کۆتایی لە کۆنگرەکەمان بریتیە لە کلۆزین سێریمۆنی لەگەڵ دابەشکردنی هەندێک خەڵات بۆ میوانەکانمان. حەزەکەم بە زمانی ئینگلیزی قسە بکەم بۆی هەموو تێبگەن. So we come for the last session or last part of our conference, Kurdistan Digestive Day, 4th one. Really, we are glad to gather together as one family. I like to express my thanks to all who participate and support this great event, especially the scientific committee, organizing committee, social committee, and even the financial committee. Thanks for the Health Awareness and Education Center in organizing the conference, and for the iHealth, which is a supporting part to cover the recording all the events successfully. I like to express our thanks for the sponsor, all of them, each according to the level of the participation. A good number of drug companies support us. Without them, really, it was not easy to conduct this nice conference. And great thanks for all participants, especially the speakers, for all participate, especially from outside Iraq, for our colleague team from the Egyptian, from the Islamic Republic of Iran. Unfortunately, our guests from Iran, they leave this morning early because they have some appointments. And also, we like to thank the Grand Millennium Hotel for their hospitality and this nice facility that they afford. Thanks for you all, one by one, all who attend, specialists, junior doctors, postgraduate students, rotator, nurses, pharmacists. Thank you again. In the name of the Kurdistan Association of Gastroenterology and Hepatology, I like to express my thanks for your attendance and for your patience. Was a bit busy program, and really we cancel many because there was so many other talks, but because of the time we couldn't accept all of them. Thanks again. Now we will start giving some of the appreciation certificates for our distinguished guests. دكتور عبد الفتاح ناو كان في النوبة بريز باش. The first is Professor Ustad Mahdi Fayyad, please.
بدينا society 1979 refused 1980 81 82 83 88 and then at last society 1992 صارت هذه society تنفكر كونغرس مثل ما سبورت مال الكومبانيز طبعا ثانك يو فور ذا كومبانيز فور ذا كوليج هو شيرد حقيقه صار جمعيه كان هدفنا العراق كله في كل محافظه يصير مركز عراقي ودراسات تخصصيه والحمد لله صار الحقيقه اللي شفته بهالمؤتمر هذا نسبه الشباب اللي جو خاصه البنات مالنا الحمد لله يعني واحد يفرح القلب ليديز يعني 4 5 في نفس الوقت محاضراتهم ما ماخذيها وشفنا شباب يسوون ادفانسد تكنولوجي هاي ادفانسز مع زملائنا المصريين فشيء this is state of the art. We are very happy to have this Congress in this year. We hope we have the time to share again in the future if God give us more time. Thank you very much, Mohammed, for all the colleagues who are with us. And this from the heart, I'll transmit this message to also to the Iraqi society, the International World Congress Gastroenterology, and I'll share you with the coming program ECHO that we share all in, inshallah. Barakallah. حبيبي الله يخليك.
ألف مبروك أستاذ مكي. I always regard him our teacher and our godfather in GIT. God bless him and we hope for you all health إن شاء الله. تبقى الشباب ويانا إن شاء الله على طول. حبيبي الشهادة كمان.
تغرقونا أنتم محمد.
بعد
غرقتونا.
تستاهل أكثر. هذا شيء بس سيمبول. آمين.
احنا نقول له خلونا اخر واحد هذا كل شيء اخر واحد انا زوير قصير ذكر اي والله الله يرحمك يا زوير اي والله الله يبارك فيك.
بس على الكاميرا استاذ
حبيبي الله يخليكم تسلمون شكرا جزيلا حبيبي يحفظك الله يخليك الله يبارك فيك.
ممنون.
تسلمون.
The second is دكتورة نوال الخالدي. ونائبة نعم.
شكرا جزيلا. ما أعرف شلون أعبر عن سعادتي عن المستوى العالي والراقي والمتطور لهذا المؤتمر. يمكن لحد الآن هذا المؤتمر هو كان أكبر مؤتمر بكل التفاصيل مالته وطبعا متواصل مع ما وصل إليه GIT بغير مكانات بالعالم. فسعيدة جدا وأبارك لهم إن شاء الله من تقدم إلى آخر بالتوفيق.
ألف مبروك. دكتورة نوال. شكرا جزيلا. طبعا بدون مجاملة دكتورة نوال is one of our colleagues that always supportive. She served GIT in Hawlier several years, and for every exam I invite her, and she's always ready to participate and support. Thank you very much again. أستاذ جمال عميرة، أستاذ الكبير، شرفتنا ونورتنا والله يعطيك طولة العمر والصحة إن شاء الله. Thank you very much.
I am very happy to be here, and I thank all of you. I thank the organizing committee. I thank the scientific program, and I hope we share next year, and I hope you come all to Egypt. Thank you.
والشهادة هاي كمان شهادة المحاضرات لأستاذ. شكرا لأستاذ جمال for his participation, and also we hope for good health for him. Yes. And the next is our dear colleague, Professor Aras Aziz, Program Director of Gastroenterology and the previous Dean of the College of Medicine.
Thanks for your presence in this beautiful and informative and scientific conference about gastroenterology and hepatology, and we hope what we do in Kurdistan to add a little bit to the, not only at the level of Iraq, to the level of the Middle East. Thanks for all, and thanks for the organizing committee, which I am a member, for all committees who have participated in the success of this conference. Thank you.
Thank you very much, Dr. Now, male, female, okay. Next, Dr. Samar from Kirkuk. Dr. Samar Saad Abdel Hussein is the gastroenterologist in Kirkuk, and also she is very cooperative, supporting always our student and in the examination, and thanks for her support and collaboration always with us. Welcome, Dr.
Thank you, Dr. Mohammed. Thanks for the organizer to make me part of this nice scientific events. Thanks for your hospitalities. We are all proud of your achievement, and we hope more success for all. Thanks.
Thank you very much. أيوة علي كوا علي أوي إيه Okay, the next is Dr. Ali Abdul Ghani Ramadan, one of the first graduate of Kurdistan Board for Gastroenterology, and he is now responsible for the GI Center in Duhok, and thanks always for your collaboration, Ali.
Thank you for your attendance. We hope the continuity for these digestive days, and we thank you, our masters, for all of their support and for all they did for us. Okay.
And our next, yes, Dr. Abdullah Saeed Dilmani. Abdullah represents the Hawler branch for the Kurdistan GIT Association. Abdullah Jan Piroza, welcome, welcome, dear. Please.
Thanks for my teachers and for my brothers. Congratulations for our successful meeting, and I hope more success in the future.
Thank you very much, Ali. Abdullah. Thank you, Abdullah. Bash. Then we have some also appreciation letter for the sponsors that support the company. Of course, for all our colleagues from the Egyptian also, we made certificate, but because till now they are working, as my colleague told me, Dr. Dana, Dr. Martin, they visit them. حتى استيجا كان لأنور شيخ. So we appreciate their effort, but unfortunately they are not now with us, but their certificate and appreciation letters are done for all of them. Chaplay Chan Bolian. الله يسلمك. أنا ما أحتاج أشكرك. أنت تعطيني. Thank you very much, Dr. Nawal, for your appreciation. أما بو شيء معنا. كواهي شركاتك كان معنا. باش. بس تونا وكان بريز في ما بقول بوي. هلا سر وش بيخويني توانية. خوان نونا ركانيا ليريا. طبعا أكو مثل عربي يقول اعذرونا عن التقصير. الكمال لله. I know nothing is perfect 100%. We try our best, but still maybe there are points, but always there is place for improvement. يعني دائما حولين باشتر بين وزارج كش بوهمو أواني ليرن وأوانش كنيان تواني وبين من بناوي خومو بناوي كومالكو داوي لبردنيان ليكين لو أني زاري وأنا كمان بيرسو بيا خوان خواسته لكمينية. We may forget some name. This is not intentional. Maybe missing or some collaboration may be weak. I admit that our announcement for the conference was a bit late. Inshallah, for the next conferences, we should announce it more than 6 months in advance. And this is your society, this is your association. Please don't feel that you need someone to invite you. Please come and participate and ask and call. This is for no one. society نهي دكتور محمد عمر ونهي هو أبو بكر ونهي كدكتور عراس ونهي كسا هي همو معنا. So we should all work together. If in this conference Dr. Aras has no presentation, the next will be the next. We have too much, and we think, inshallah, in the near future, if next year we plan to do it, we may do it now next year in Hawler, and other year in Duhok, or other year in Kirkuk, etc. There is no restriction for any place or for any person. We are all together and we are nice together, anywhere, anytime. Thank you again. باش تو ميوانا كان بانك ومن أستاذ مكي تفضل هم نوال دكتور عبد المنعم حتى توزعون الهدايا على الشركات إذا مزح ما نحب. أشكرك أنا ما أريد.
برزان مكاتم باش سپاسان دەکەین تحملتانە و تا گەشتن لە کۆتایی لەگەڵمانە. شەریکاتەکان طبعا دکتۆریا بە بۆنەوەی کە تەخیر بوون لە شێخەمەوەڵ تەوقیعەکەی نەکراوە تۆ زەکتر دەگاتەوە ئێرە تەوقیعی شەریکاتێکا بەدەمە دەست بە تەوزیعات دەکەین لەبەر کاتیەوە بگەڕینەوە. Now we start for the golden sponsor. We have 4. We start with the Green Ivy company. دكتور محمد.
أستاذ جمال يتفضل بتوزيع بعض من الهدايا. شريكي
Green Ivy.
Green Ivy.
After that, Johnson. Yes.
بخير. Next.
Johnson.
شركة جونسون.
After that, Aquamed company.
Aquamed company. Yes.
الظاهر انت غطيت كل شيء بالسوق ما كمان.
طبعا.
فرحانين بيكم غطيتوا كل شيء بالسوق ما بقى
شيء. في
do I have high quality Anwar Sheikh Hospital? AstraZeneca as a silver sponsor.
دكتور النوال.
ئێمە شەریکێکی مالایە لەم کۆنفرانسە بەشداریمان کردووە بە ئایتمی لیف 52 بۆ فاتی لیڤەر و
After that حكمة.
في شركة RDA Expert شاركنا في المؤتمر الرابع لجهاز الهضمي في السليمانية بجهاز الفايبروسكان
كزليرانية لحكمة يشي للشركة كاني كبي وري قريبوي هم الرفيقية كان خيرا يشي كتان بيت بس حكمة يعني ولا
بالتوفيق إن شاء الله.
جولفار.
ئێمە وەکو شەریکەی ئێسبی بەشداریمان کردووە لە کۆنفرانسی GIT بە مادەی ئۆکتیۆتاید ئۆکترا کە بەکاردێت بۆ پانکرێاتایتس ئافتەر سەرجری.
ئێمە وەک شەریکەی جولفاری ئیماراتی بەشداریمان کردووە لە کۆنفرانسی GIT کە بە
Vera Health Company.
بەکاردێت بۆ کەیساتی GIT H. pylori eradication and ulcer.
Vera Health. Okay. Himalaya Company.
Himalaya Company.
شاری پزیشکی نوشەخۆ و نەخۆشخانەکانی هایکوالتی بەشدار لە چوارەمین کۆنفرانسی نەخۆشیەکانی
ESB.
کە لە شاری جوان
ئامادە کراوە
Yes, big group.
خوشحاڵی و تاکە نەخۆشخانەی کە بەشداریمان کردووە بۆ کردا هەناویانی کە ئەنجامە دێکە تاکە نەخۆشخانەی لەسەر ئاسی عێراق کاتوانە قەیدانی تێدا ئەنجام بدرێت لە بوسەکەشمانە باسی پێچکان دەکەین کە ئێمە تاکە سەردەرین لە سلێمانی کاتوانین خزمەتگوزاری پێچکان بۆ چارەخوازان ئامادە بکەین.
And now we start with the bronze sponsorship drug company.
وكلاء شركة فوجي فيلم اليابانية سعيدين جدا بالاشتراك بمؤتمر الرابع لأمراض الجهاز الهضمي والكبد. اليوم اشتركنا
Pioneer.
اللي تعتبر من أحدث الأجهزة في مجال
Pioneer. كواهو باش.
هاوباش.
يكشك مشكلة ندي. أنا لا.
Desma company.
Desma.
Piano travel والله فاكتور. Alpha Medical Company. Okay. زمان للنيا. Fuji Company.
ئێمە وەکو شەریکەی پیجێ فارما بەشداری چوارەمین کۆنفرانسی GIT مان کردووە لە سلێمانی بە ئایتمی کۆلۆلاکس کە بۆ کەیساکی باول پریپەرێشن هەروەها کۆنستیپێشن بەکاردێت.
ماکێنزی.
ئێمە وەک شەریکەی سترۆنگ تایگەر وەکیلی سەرەکی شەریکەی ئیبسن لە عێراق بە مادەی فۆرترانس بەشداریمان
ماکێنزی.
ماکێنزی دکتۆر هانی.
ئەوە مێدیکا.
لا هو وطمان ليرني الميخر وبردمي وطمان هاو ميديكالي ماكنزي هير ماكنزي
نعم
هاو ميديكا هاتو
هاو ميديكا وكاكتو
نكاني بحاليات بو IBS irritable bowel syndrome constipation ودايريا
خوشحاڵین وەکو شەریکەی ئەسینۆی سویسری کە بەشداریمان کردووە لە چوارەمین کۆنفرانسی هەرس و جگەر
ئەلێرتی
بە ئایتمی گاسێک کە چارەسەرە بۆ ترشەڵۆک و کێشەکانی گەدە
حبيبي استاذ وردة
ئێمە شەریکەی نێزلاوی فەڕەنسی بەشداریمان کرد لە چوارەمین کۆنفرانسی تایبەت بە نەخۆشیەکانی هەرس و جگەر لە کوردستان بۆ ئایتمی ئیسۆگاس کە بۆ نەخۆشیەکانی ئێسپایلۆری ئیریفیکیشن بەکارێت لەگەڵ جێر وهروها بۆ حاڵەتەکانی GIT absent.
Epson Drug Company.
ئێمە شەریکەی ئەلفا مێدیکال بە دوو مۆدێلی ئامێرەکانی سۆنۆسکەیپ بۆ هەناوبینی بەشداریمان کردووە.
MS Lab
کە هەناوبینی گەدە و کۆڵۆن و دوانزەگرێ و هەناوبینی سۆناری ئەنجامەیە.
ئێمە وەکو شەریکەی ئاومێدیکا بەشداریمان کردووە لە چوارەمین کۆنفرانسی GIT بە بەرهەمی مێتازا مێسەلازن کە بەکاردەهێنرێت بۆ ئەلسەرەتیڤ کۆلایتس هەوکردنی برینی ڕێخۆڵە.
MS Lab
ئێمە وەکو شەریکەی وەڵمێدیسن بەشداریمان کردووە لە کۆنفرانسی GIT بە ئایتمی
CBMed
کە بۆ irritable bowel syndrome بەکارێت.
RDA No نتأخر أنا بقول أنا كنا هاتونا ما نعمل World Medicine Company. Okay, دخل بحاجة ليش يكتن ستك General Care Pharma.
سپانسر بەشداریمان کردووە بە ئایتمی لی 52 بۆ فاتی لیڤەر و elevated liver enzyme.
شاركنا في المؤتمر الرابع للجهاز الهضمي في السليمانية بجهاز الفايبروسكان والذي يعتبر هو الجولد ستاندر نون انفيزيف فور liver fibrosis and liver
أبوت فارما أبوت إنما طلعوا
ئێمە وەکو شەریکەی ئێسبی بەشداریمان کردووە لە کۆنفرانسی GIT بە مادەی ئۆکتیۆتاید ئۆکترا کە بەکاردێت بۆ پانکرێتایتس ئەفتەر سەرجری.
ئێمە وەک شەریکەی جوڵفاری ئیماراتی بەشداریمان کردووە لە کۆنفرانسی GIT کە بە ئایتمی گۆردێکس کە بەکاردێت بۆ کەیساتی GIT H. pylori eradication and ulcer.
دسمة باشا ثمان كان
دكتور برهم
فارمای ئۆردنی بەشداریمان کردووە لەم کۆنفرانسا کە ئایتمی پێکتۆزمان هەیە بەکارهێنرێت بۆ تریتمەنتی H. pylori eradication.
شاری پزیشکی نۆشەخە و نەخۆشخانەکانی هایکوالتی بەشدار لە چوارهەمین کۆنفرانسی نەخۆشیەکانی هەرس و جگەر کە لە شاری جوان ئامادەکراوە و ئەم کۆنفرانسە بە خۆشحاڵی و تاکە
Dr. Barham is the director of the gastroenterology pathology. He is consultant
media
surgeon.
communication. كاك اسماعيل دەستیان خۆش ئێشێکی جوانیان کرد لە حەقەتە.
کاتوانین خزمەتگوزاری پێچکان بۆ چارەخوازان ئامادە بن.
ئێمە وەکو دامەزراوی میدیایی ئایهێڵس یەکەمین میدیای تەندروستین لە هەرێمی کوردستانە بە خۆشحاڵیەوە ماوەی مانگێکە سەرقاڵی ئامادەکاری بۆ ئەم کۆنفرانسین سپاس بۆخوا سپاس بۆ هاوکارانمان سپاس بۆ میدیاکاران کە لەگەڵمان هاوکار بوون توانیمان بە باشترین کوالیتی چ ئەو مولایڤانی کە گواستمان وازان یەکەم جارە لە هەرێمی کوردستانە بەم جۆرە بەم کوالیتێ بەرزە کۆنفرانسە گوێزرێتەوە هەموو لە هەموو سۆشیال میدیاکانی خۆشمانە کۆی گشتی کۆنفرانسەکە ئێستا بوونی هەیە ئێمە توانیمان کۆنفرانسەکە بگوێزینەوە سپاس بۆ ئامادەکارانی چوارەمین کۆنفرانسی نەخۆشیەکانی هەرس و جگەر لە سلێمانی.
زۆر سپاس بۆ ئەو یەک کەلیمەیە. دێسمە represent of دێسمە
ئێمە وەکو شەریکەی PJ فارما بەشداری چوارەمین کۆنفرانسی GITمان کردووە لە سلێمانی بە ئایتمی کۆلۆلاکس
ئەسینۆ
ئەسینۆی سویسری
ئەسینۆ ئۆکەی
کەس نایەوێ
مەکەنزی
مەکەنزی دکتۆر هانی هانی جان دەست خۆش پیرۆزە
خۆدەوەی تۆ بەرهەمدا
ئێمە کۆمپانیای میدیکال مادین بەشداریمان کردووە لە چوارەمین کۆنفرانسی GIT بە ئایتمی
And also I like to give appreciation to my colleague Dr. Barham.
خۆشحاڵین وەکو شەریکی ئەسینۆی سویسری کە بەشداریمان کردووە لە چوارەمین کۆنفرانسی هەرس و جگەر بە ئایتمی گاسێک کە چارەسەرە بۆ ترشەڵۆک و کێشەکانی گەدا.
ئێمە وەکو شەریکەی هێمێزلاوی فەڕەنسی بەشداریمان کردە چوارەمین کۆنفرانسی تایبەت بە نەخۆشیەکانی هەرس و جگەر لە
دوایە مشکلة
بۆ ئایتمی
طوانية.
بۆ نەخۆشیەکانی
So thanks for you and thanks for all. Yesterday at the end of the last Thursday we took a photo. Some of our colleagues were not present, so I like to have a second photo together. بس جيب الكراسي قدموا الكراسي کاکە بەسی ڕیزێ لە پێشەوە لێرا بوەستن منم ڕیزە لامووی جوانتر دەرەچێ ئەوانەی تۆزێ بەتەمەنن کورسی مجموعەیە کورسیمان بۆ بێنە کورسی ئەو کورسیانە عفوا دقيقة نوال يعني ترتيب دي أولا دواء داينة دواء يجيبون هسه كراسي أستاذ جمال تفضل أي عبد الله فرقناك شيء هيلا تفضل دكتور أوي دارە دانیشن ئەو کورسێ جووت کە ئەوان وەرن هەمووتان بۆ وەستاون وەرن خێرا مجموعەیە بێنە سەرەوە ئەوانەی باڵا بەرزن وەرە ئەنوەر شێخە های کواڵیتی وەرە هەمووتان کەس نەمێنێ لە خوارەوە هەندێک لەویە دکتۆرە سەمەر حەزەکەی بێتە سەرەوە کورسی تخوا بڵێ چەند کورسیەکە گەر هەیە بۆمان بێن لە دواوە شوێن زۆرە وەرنە دواوە تۆ خەمن نەبێ لێرە شوێن زۆرە جێی دە کەزە بێ لێرە بەس جوود بن بە یەکەوە سەو صفوفەکم دیار ژیان تۆز بەرن بەملاوە بە با نەگوشتێن دەی وەرنە ئێرەوە شوێن زۆرە لێرە بۆ لەوێ تۆپەڵ بوون کاکە وەرنە ئێرەوە خێرا تۆ زێ بجوڵەی دکتۆرە یەک تۆز بۆی مەجال بێ دەی کاک بجوڵێن يلا جاي بكرواني او بلا بنت انا جيبته عيبيني ورجي دكتور زان شلون فيوكا بيجوا زان او هنا درجات بلا ديال او يبردني سازان وەرە خێرا ڕاکە وتم کەس نەمێنێتەوە بۆ لەوێ ئاوەستان ئەوانە بۆ دانیشتون ئەو چاوەڕێی پاسەکەن چی لەم سەر لێرە شوێنەیە سازان وەرە ئێرە ئەمە بۆ یادگاریە مێنێتەوە لە هەمووی خۆشترە یەک دوو سێ بکە بە يلا محمد مجهولين جاري تا درونا كجد لازم ما ترسل صاروخ يك دق مجولين اوابتن يعني اواب فنجي اواليبكن فنجيك يعني اوكي يا دوسي كواي كده شفتوا حركات ولا مكان يا دوسي مبروك استاذنا عيني نواز شرفتينا نورتينا
مبهورين والله كل شيء، عاشت الايام.
شكرا دكتور حبيبي عزيزي الله يعزك الله يخليك حاجي كامل جان قولوا كردي براي بريز سرسر حبيبي ويلكم انت وين كنت؟
انا كنت موجود فوق
انا اسف
لا
الجماعه هناك
خالص
انا اسف لازم ناخذ صوره بس يجي قربان
كويس انا هاخد رقم حضرتك
اكيد اكيد
خلاص